Assalamualaikum and good morning, everyone. Welcome to the Breakfast Health Talk. So I am Dr. Redzwan, one of the ENT specialists from the ENT department. So I'd like to introduce you today to our first speaker, who is also not just the head of department of ENT, but also a alumni. So Dr. Gagan is also a rhinologist and also a skull-based surgeon in the department of ENT. So he'll be presenting a topic on rhinosinusitis today. So without further ado, Dr. Gagan, the session is yours.
Perfect. Hi, good morning, everyone. I'm here to talk about rhinosinusitis. Thank you, Dr. Redzwan, for your very kind introduction. So rhinosinusitis is a situation or condition where almost all of us, I believe, would have experienced at some time. And today I'm just going to give everyone an update to an overview of what rhinosinusitis is, and also what are the different types of rhinosinusitis, what you should look out for, and what we can do. So basically, we will define rhinosinusitis, and then we will divide rhinosinusitis to infective and non-infective causes. And importantly, what are the red flags when you have rhinosinusitis? What are the complications of rhinosinusitis which are serious? And then we will also review the management options within the armamentarium of the ENT. So firstly, it's very important to understand how the nose reacts to any particular trigger. Now, triggers can be various. Like I said, the trigger can be an infective cause or a non-infective cause. And whenever these triggers, the nose experiences triggers, what happens is there's increased permeability of the mucosa of the turbinates. And this results in venous congestion and edema. And the clinical manifestation is you get a blocked nose. There's also increased prostaglandin and mucus production, which also results in a runny nose. And these two combined in itself will cause sneezing. So even without histamine release, even without cytokine release, when your nose is congested, when your nose is blocked, the natural physiologic response is to have a sneeze, to blow out and clear out all those secretions. Now, on top of that, when you have an allergic component, there is release of histamines and cytokines, and they also can contribute to these symptoms of sneezing and itchiness. So when you have a congested nose, which is blocked and having a lot of mucus, then your sinus ostiums get blocked, and this results then in facial pain. And if your olfactory epithelium, which lies at the roof of your nasal cavity, is blocked by this mucus and edema, then you'll develop olfactory symptoms where you can't smell. So most of us would have had this. Whenever we have a viral respiratory tract infection or a flu, we get a blocked nose, runny nose, with or without sneezing. Sometimes we get facial pain, and of course our sense of smell goes down. And of course, with our sense of smell, our sense of taste as well goes down. So what is rhinosinusitis? Now, rhinosinusitis is basically inflammation of your nasal cavity as well as your paranasal sinuses. So that's why we call it rhinosinusitis. It's both in the nose as well as the sinus lining. It usually presents with nasal symptoms, like I've mentioned earlier, and also facial discomfort. Now, it's very important in the history to classify your duration of your symptoms, right? Whether it's acute, which is less than 4 weeks, subacute from 4 to 12 weeks, and then chronic, which is more than 12 weeks. And these phrases also become very confusing for us sometimes when we talk about what is rhinitis, what is sinusitis, and then why are we using this phrase rhinosinusitis? So I've got a diagram here of the paranasal sinuses, as we can see. So we've got 4 pairs of paranasal sinuses. If you can see, the ones in the top is your frontal sinuses. In between your eyes, you've got your ethmoidal sinuses. Underneath your eyes, behind your cheeks, you've got your maxillary sinus. And the last pair of sinuses are actually located posteriorly, right in the middle of the head. And those sinuses are called sphenoid sinuses. Now, all these sinuses drain into the nasal cavity, and they go back into your nasopharynx, and you swallow the mucus that is produced. Everybody will produce some amount of mucus from their sinus every day. And that mucus is basically moving towards the nasal cavity, and then it goes to the back. Now, whenever your nose gets triggered for whatever reason, whether it's an infection or whether it's a non-infective cause, when you have this edema, your sinuses get blocked. Now, when your sinuses get blocked, you get a collection of mucus within your sinus. If the infection is within the sinus in itself, and there's no issues within the nasal cavity, then it's called sinusitis. If the inflammation is within the nasal cavity alone and not going into your sinus, then we call it rhinitis. Now, in my experience, it is very, very rare that an inflammation process that's going on in the nose does not spread to the sinuses, because the moment the nose gets congested, the sinuses get blocked. So rhinitis will result in sinusitis. Now, there are certain conditions where you can develop sinusitis by itself, especially if you look at this diagram. If you have a tooth infection, your nose may be completely normal with no symptoms, but if you have an infection in your tooth, you can develop an infection in your sinus, and that is sinusitis by itself. Most of the people, when they have a common cold for the first 1 or 2 days or 3 days, their symptoms are mainly within the nose, and sometimes they have a good enough sinus drainage pathway. They do not get a blocked sinus, so their symptoms are mainly within the nose, and we call that rhinitis. But by and large, whenever there is some sort of inflammation within the nose, you will see some effects in the sinuses as well. So I hope that gives you a very clear picture and understanding of the difference between rhinitis, sinusitis, and why we ENTs use the term rhinosinusitis as well. So how do you go about it? Like I said, rhinitis symptoms are mainly nasal because of your nasal irritation, whether it's an infection, whether it's an allergy or non-allergy. Sinusitis is mainly in the sinuses, and sometimes people can have a bad structural problem within their sinus pathway or the sinus drainage pathway. So these patients do not have an infection, they do not have an allergy, they do not have any other contributing factors, but basically because of the architecture in their paranasal sinuses, there is a blockage in the sinus itself, and this can cause sinusitis. However, we don't see this in a large group of patients. Most of these patients will have a nasal symptom or a nasal problem that causes the sinus to get blocked. If you have a mass or a tumor within your sinus pathway, then that mass can obstruct your sinus pathway, and that itself can cause you to have a sinusitis, where you have very little nasal symptoms, but you have sinusitis symptoms, which is predominantly facial pain, facial heaviness, and facial fullness. Like I mentioned earlier, if you have odontogenic causes like an infection, especially in your upper molars, the roots sometimes tend to go right into the maxillary sinus, and that can cause you to have a maxillary sinusitis. We can also see this in patients post-dental procedures, where sometimes you can get an infection within the socket, and that infection can actually spread into the maxillary sinus. Of course, in certain cases of trauma as well, especially with facial fractures, the bony architecture of the sinus drainage pathway can get affected, and those patients tend to develop sinusitis symptoms mainly. Now, invariably, if both get involved, then we classify these patients with rhinosinusitis. And the reason being, by the time these patients come to see us, the condition has been long-standing enough for both the nose as well as the sinus to be involved. So how are we going to classify rhinosinusitis? Now we know the symptoms. Patients will come in with symptoms of a nose block, they will complain of mucus, they may complain of facial pain, and invariably these symptoms may overlap between sinusitis and rhinosinusitis. The key distinction here is whether the condition is infective and non-infective. So if it's infective, which is the vast majority of causes, there are certain causes for these infections. And if it's non-infective, then we go through the history and we try to classify what they are. So the most common causes of infective rhinosinusitis are viral, about 80 to 90%. And sometimes they can get a secondary bacterial infection. And of course, the third group would be fungal infections. Fungal rhinosinusitis, where you can get an invasive fungal sinusitis versus a non-invasive fungal sinusitis. And the reason we use these terms are basically because invasive, by the name of its nature, it invades into surrounding structures and causes significant structural damage, whereas the non-invasive follows a more indolent pathway. So basically, a viral rhinosinusitis basically follows a common respiratory tract infection. You may get a sore throat, you may get a ear infection, and the mucus that is draining, it causes you to develop these nasal symptoms. Generally, they are less than 10 days. Most of the time, the treatment is supportive. The main culprits of viral rhinosinusitis would be the human rhinoviruses, the coronaviruses, the adenoviruses, influenza virus, parainfluenza, RSV, and also a few others. Now, the classic symptoms of viral rhinosinusitis, basically clear nasal discharge, blocked nose. They may or may not have a fever, but mainly the symptoms are very short-lived. So that's how we make that distinction. Now, when you have a viral rhinosinusitis, most of them recover, but about 10 to 20% of them eventually develop a superimposed bacterial infection. And the reason of that is because of the stasis of the mucus. It's a great medium for the bacteria to proliferate. It depends on the host factor as well. The ventilation within the sinuses is not good. So these conditions create a great situation for a bacterial infection then to manifest. So how would we suspect a bacterial infection? The symptoms are lasting more than 10 days. Or we get a double worsening. So what's a double worsening? The patient has a viral URTI or URTI symptoms for the first 3 to 5 days, seems to be getting better after day 6, day 7, and then on day 8, they fall sick again, they have a lot of malaise, lethargy, there may be mucopurulent nasal discharge, either greenish or yellowish. This is accompanied by fevers after 5 to 7 days. These are the times where we suspect a bacterial rhinosinusitis is going on. And the common organisms would be strep pneumo, Haemophilus influenza, and Moraxella catarrhalis. This is the point where the ENTs would then initiate antimicrobial therapy. We generally start with augmentin, and if it doesn't recover, then we take a swab. As a routine, we don't take a swab for every bacterial rhinosinusitis, but only for failure for treatment with the first-line treatment. And the next topic I want to talk about is fungal rhinosinusitis. So fungal rhinosinusitis is a very unique rhinosinusitis where the treatment is always surgical. There is no real role for medical therapy except for a few instances where we use intravenous antifungals as an adjunct. So fungal rhinosinusitis is divided into the non-invasive type, which is basically a fungal ball, a mycetoma that develops within your sinuses. The most common would be within your maxillary sinus. And the reason this fungal ball develops is because of poor ventilation within your sinus. Your symptoms are going to be very similar to those symptoms of rhinosinusitis. You may develop some facial discomfort, facial pain. You may have some mucopurulent discharge. But the important thing is the history in fungal rhinosinusitis is not acute. The patients tend to have a long-standing history of facial disturbances or facial symptoms, and it can last from months to even years. Most of the time, fungal balls are found as an incidental finding in older patients who come in for a stroke, and they get a CT brain, and then they find some fungal ball within the sphenoid sinus or the maxillary sinus. By itself, the fungal ball doesn't really cause significant symptoms. It doesn't turn invasive, and like I said, it generally causes very, very mild symptoms. Most of the patients live with a fungal ball and don't even realize they have a fungal ball, thinking that their nasal symptoms was something that they were living with. The next topic about non-invasive fungal rhinosinusitis is allergic fungal rhinosinusitis. Now, this is a combination of a fungal infection as well as an allergic response towards these fungus. And this condition tends to be bilateral, and they also tend to have a significant allergy component of sneezing and itchiness in their daily symptoms. This group of patients also require surgery. There is a classification system where we use to classify allergic fungal rhinosinusitis to confirm our diagnosis. The treatment of allergic fungal rhinosinusitis is again surgical to open up and ventilate the sinuses, followed by allergic therapy, which I will talk about later as well when we talk about allergic rhinitis. Now, the invasive, thankfully, is a little bit more rare, but we do get invasive fungal rhinosinusitis, and this is a very serious condition. It is divided into acute, where symptoms develop within hours, days to a week, and chronic, where these symptoms are going on for weeks to months. The granulomatous type of fungal rhinosinusitis is not seen much in Southeast Asia, but it is very common in the Indian subcontinent and places like Sudan. Treatment for granulomatous fungal rhinosinusitis is also surgical. So the risk of fungal rhinosinusitis is definitely higher in immunocompromised patients, patients with very poorly controlled diabetes, patients undergoing chemotherapy, post-transplant patients, or patients who are getting long-term steroid therapy. And the danger with acute invasive fungal sinusitis is the patients generally present already very ill. They tend to be septic, they may require a few different inotropes, and when you look into the nose, you find a lot of necrotic eschar. And the main treatment for that is to debride as much of unhealthy tissue there is, bearing in mind that the orbit or the eye is very near, as well as the skull base is very near to the nasal cavity. So we have to have that balance between how much we remove and how much of morbidity goes to the patient. And these patients also will require intravenous antifungal therapy. Now, moving on to the non-infective causes of rhinosinusitis. Non-infective rhinosinusitis is divided broadly into an allergic rhinosinusitis, or what we know as allergic rhinitis, as well as non-allergic causes of rhinosinusitis. And this is where a lot of people have a conundrum, because it's very clear when you have an infection, you're totally normal, you don't have any symptoms, and then you develop a URTI and you know, okay, I'm having an infective flu. But for the non-infective rhinosinusitis, these symptoms tend to be there throughout the year. It waxes and wanes. Sometimes you don't have it at all in your youth, and then in your adulthood, you develop it. Or sometimes you don't have it at all, or you have a lot of nasal symptoms when you're young, but as you grow out of it and you're an adult, you don't have these symptoms. So I think that's where a lot of people have a confusion of what they are. So allergic rhinitis is a very common condition in Malaysia and also throughout the world. Global estimates put it at about 20 to 30% of the adult population in the world suffer from allergic rhinitis. Now, what is it? It's an IgE-mediated inflammation. It's a type 1 hypersensitivity response. It is associated with asthma, atopy, things like dermatitis, allergic conjunctivitis. They tend to have these symptoms concurrently with allergic rhinitis. It is divided into seasonal or perennial. In Malaysia, because we do not have the weather systems, most of our patients are perennial, whereas in the Western world, with the release of pollen during certain months, then they can be classified into seasonal allergic rhinitis. You need to have 2 of the 4 symptoms. So 2 of the 4 symptoms are nasal blockage, nasal discharge, itchiness, or sneezing. If any patient develops 2 of the 4 when they are exposed to a particular allergen or trigger, and in Malaysia, the common triggers are dust mites. We have soy, peanuts, we have milk, we have animal, dander, so things like dogs and cats. And some patients are very clear. They say, doctor, when I eat shrimp, my symptoms will start. And what are your symptoms? My symptoms are nose block, I get an itchy nose, I start sneezing. So you know these patients very characteristically have a known trigger, and when they're exposed to the known trigger, they develop these symptoms of rhinitis. So from the clinical history and your endoscopic findings in the nose, we can make a diagnosis. And for a vast majority of my patients with allergic rhinitis, the diagnosis is really in the history. Now, the gold standard for diagnosing allergic rhinitis is a nasal provocation test, where we take the allergen at the end of a stick and we insert the stick into the nostril of the patient, and we expect a sneeze response. But that test is quite provocative. That test is also quite uncomfortable, and it's not usually done. Other tests include things like serum-specific IgE, RAS testing, and also skin prick testing. These days, we tend to go more towards serum-specific IgE because it is not so invasive. When you do a skin prick testing in our clinic, we test for 20 different allergens, and it requires 20 different piercings. So intradermal skin prick testing is moving out of favor these days. It still has a role for certain types of dermatology conditions or conditions where we are in a diagnostic conundrum, but most of the patients undergo a specific IgE testing for allergic rhinitis. Now, when you come to management of allergic rhinitis, the first thing is to avoid the triggers as much as we can. There are certain things we cannot avoid. For example, dust mites. As much as we want to, we can control our home environment. It's very important to tell patients that dust mites do not die when you wash them in the washing machine, any of your linen. It's important to heat up your linen or soak your linen in about 55 degrees temperature Celsius for about 10 to 15 minutes before you wash them. This process kills the dust mites, and then you do not have these dust mites living within your bed sheets. And the same should be done for curtains. So dust mites is one of the main triggers for allergic rhinitis in Malaysia. Apart from washing your linen in hot water, try to avoid having carpets in the room. Curtains should be washed frequently, and aircon filters should be changed. Now, whenever, of course, rooms are being cleaned, the patient should not be in the room or the vicinity of the area, because dust particles will then trigger another allergic rhinitis flare-up. Now, when we come to non-allergic rhinitis subtypes, and this is where some ENTs as well get themselves a little bit confused because there are so many different subtypes. So vasomotor rhinitis is basically due to autonomic dysregulation. Certain times you go from a cold room to a hot room, your nose doesn't catch up with the change in temperature. The nose only reacts in one way. It causes you to get a blocked nose and a runny nose, and that's mainly due to autonomic dysfunction. Non-allergic rhinitis with eosinophilia nares is another diagnosis for patients with non-allergic, where they develop high levels of eosinophil, mainly with rhinitis symptoms. Occupational rhinitis is mainly related to different solvents and different chemicals people are exposed to in various different workplaces. So your symptoms are basically triggered whenever you're going to work, and whenever you're stopped work or whenever you're away from work for a week or two, your nose clears up. So that's very characteristic of occupational rhinitis. Hormonal rhinitis is mainly seen during pregnancy. Changes in levels of estrogen and progesterone causes vasodilatation, edema, and these patients then have very blocked nose during their pregnancy, and their symptoms then clear up after they deliver their baby. Drug-induced rhinitis is a topic that is not really assessed much, but any patients who are starting on NSAIDs, oral contraceptive pills, ACE inhibitors, and a few different psychotropics, they also can develop these rhinitis symptoms, and need to ascertain patients with new onset rhinitis symptoms when they're adults if there's any change in their medication, because that's very important. Patients don't ask, or patients are not asked about their new medications. Atrophic rhinitis is usually seen in older patients or excessive surgery in the nose where they've removed too much of nasal mucosa. Patients develop crusting, and they have the same nasal symptoms of a blocked nose with the addition of maybe foul-smelling nasal discharge. And gustatory rhinitis is also a very common symptom that's seen when patients are eating because of autonomic dysregulation, and the nose also starts producing mucus, and patients generally develop this as they get older, as the autonomic regulation is not as tight as it was when you're younger. So as you can see, there are many different types of non-allergic rhinitis, and that's where most of the ENTs spend their time differentiating what they are. So like I said, the clinical presentation of a person coming with rhinitis would be nasal obstruction, nasal discharge, with or without facial pain or pressure. Their smell may or may not be affected depending on whether the olfactory epithelium is involved. And they also may have cough, headache, and fatigue. So how do we come to our diagnosis in the ENT? The most important thing is the history. I always believe 70 to 80% of your diagnosis comes from the history. In terms of examination, we examine everybody's cranial nerves. We look into the oral cavity. We do a nasal endoscopy. We check their ears. We do tuning fork to test for their hearing. Patients with rhinitis may develop middle ear effusions as well, so it's important to assess their hearing. If there are things that we find, we may organize a CT scan looking for chronicity of disease or any complications. And of course, if there's an element of allergy or whether there's a doubt whether the patient might have an allergy, we may also do an allergy testing. So these are a couple of images. I just want to show you the image on top is an endoscopic view of the nasal cavity. You can see the septum here on the left. You can see this nice grape-like looking structure. This is what you call a nasal polyp. A nasal polyp is basically an outpouching of the nasal mucosa due to chronic inflammatory processes. And this is the turbinate. So this patient has no airway to breathe from his nose, and you can see mucus lining the bottom of his nose. This mucus is going to go down and cause the patient to have a post-nasal drip, and patient will have frequent throat clearing as well, on top of having a blocked nose. As we go superiorly, you can see the olfactory epithelium region is not involved. So this patient may have normal smell, but a totally blocked and runny nose. Now this is a CT scan lower down. As you can see, the proximity of the skull base, the eyes, and the nasal cavity, as well as the paranasal sinuses. I also want to highlight the proximity of the roots of the molars to the paranasal sinuses. If you can see in this patient, both the maxillary sinuses have some mucosal thickening because the area is gray. Ideally, it should be all black, which indicates air. So you can see the airway as well on the right side of the patient's nasal cavity is all right, but the left is a little bit narrow, and there is a septal deviation as well in the nose. So all these symptoms are going to cause the patient to have a more profound blocked nose on the left side, as well as nasal discharge. Now, what are the red flags we need to look out for? So any patient who comes in with rhinitis symptoms, but they also complain of visual symptoms, specifically double vision. If there is double vision, it means the extraocular muscles are involved, and these tend to be the first manifestations of any tumor or any growth that is invading into the orbital cavity. The other thing is also loss of color vision. and that is related to any damage to the optic nerve. So in the sphenoid sinus, the optic nerve runs very closely. If you have a problem in your sphenoid sinus, and your optic nerve gets inflamed or infected or involved, you tend to lose color vision. The next thing is also periorbital swelling, which is basically an infection that is spreading from your ethmoidal sinuses into your periorbital region. Any patient with neurological signs or symptoms indicate that a nasal infection or a nasal problem is probably spreading intracranially. There are two ways a nasal pathology can spread intracranially. One is direct extension, and the other way is because there is a danger triangle of the face where any infection drains towards the cavernous sinus, and patients with untreated infections within this danger triangle of your face, they may develop a cavernous sinus thrombosis. Patients with severe frontal headache with rhinitis symptoms is not normal, so you need to get these patients to be checked by an ENT to make sure there's no frontal sinusitis. And any patient who's immunocompromised and comes in with new onset of nasal symptoms, especially if there's bloody nasal discharge, or the patient starts having high fevers and they're immunocompromised with nasal symptoms, those patients warrant urgent attention. So what are the complications of rhinitis and rhinosinusitis? You can develop, like I said, spread from the ethmoid into your orbit, developing orbital cellulitis. And in a worse infection from orbital cellulitis, it can even develop a subperiosteal abscess within the orbit or even an orbital abscess. Infections can spread through diploic veins and cause meningitis. Brain abscesses, whether it's a subdural abscess, whether it's a cerebral abscess, they can develop cavernous sinus thrombosis, and infections can also spread to the bone. And we tend to see this in patients who are post-radiotherapy. They tend to develop osteoradionecrosis and also osteomyelitis on top of that because of the infection and poor wound healing. So how do we manage these patients? There are a few different ways. One of them is supportive therapy. This is mainly for patients with viral infections, viral rhinosinusitis. We take a proper history and examination. We can give them some saline irrigation for symptom relief, analgesia, hydration, and we educate them that, look, this is a viral infection. It should get better. If you have a double sickening or symptoms don't improve after 10 days, come back to us. You may be developing a secondary infection. We also can give symptomatic treatment like menthol, things like Vicks or menthol for them to inhale. Now, when it comes to medical therapy, the mainstay of our treatment is intranasal steroids. We do give antihistamines when we need it. For bacterial infections, antibiotics play a role, and antifungals, like I mentioned, for specific fungal diseases. So for chronic rhinosinusitis, main treatment is long-term intranasal steroids with saline irrigation. We treat their comorbidities. In selected patients, we may consider biologics. And of course, a failure of treatment then results in endoscopic sinus surgery, where we open up the sinuses to improve ventilation and improve the delivery of medication. So when do you refer a patient with symptoms? Patients with recurrent disease, patients who are not getting better despite your nasal therapy. If you have any of the suspected complications with nasal symptoms or any of the red flags, those patients should be referred urgently. In any suspicion of a fungal disease, especially in various wards, patients who are immunocompromised and start developing altered consciousness with nasal symptoms, please suspect invasive fungal sinusitis. If there's any need for surgery, and of course, if you're not sure, you can always send the patient to us. Key take-home messages for the day: most cases of rhinosinusitis are viral. We need to classify whether it's an infection or a non-infectious disease. Try to recognize our complications early, and our treatment is tailored to the underlying etiology. With that, I thank you and take any questions.
Thank you very much, Dr. Gagan, for the presentation. Now, do we have any questions from the floor? Okay, so we have a question here. One of the questions is, at what age can we start intranasal steroid?
Okay, that's a very good question. So intranasal steroids come in various different formulations. At the moment, the youngest age we can start intranasal steroids is 2 years of age, and the medication for that is fluticasone furoate. So basically, it's Avamis nasal spray, which has a blue cap on it. That spray is indicated for 2 years onwards. But for the vast majority of intranasal steroid sprays, it is 5 years and above. So again, this can be used with the discretion of the physician, but by and large, 2 years and above is Avamis, 5 years and above is all the other intranasal corticosteroid preparation.
Thank you for the answer. So far, I don't see any more questions here in the chat, so I think it's already 8:30. We need to move on to the... Oh yes, there's one question. Any role of Montelukast for allergic rhinitis?
Okay, that's also a very good question. So Montelukast is usually given as an add-on in patients who have allergic rhinitis. When we divide them, if their symptoms are mild to moderate, an intranasal steroid and an antihistamine works. If their symptoms are not controlled, yes, we can add on, considering adding on Montelukast. If a child with allergic rhinitis has asthma, I send them straight away to my respiratory colleagues, because any patient with allergic rhinitis and asthma should be managed together between the ENT as well as the respiratory physician. So sometimes I will get the patient and I start the patient on intranasal steroids and antihistamine, and I send the patient to the respiratory colleague. And sometimes the respiratory colleague themselves has added on Montelukast. So that is quite common. Yeah, there is a role of Montelukast, to answer your question.
Thank you. Are there any other questions before we move on to our next presenter? Okay, looks like there's no more questions in the chat box. Thank you very much once again, Dr. Gagan, for the
Okay, thank
presentation,
you.
and thank you everyone.